Oh, shoot. Morning. Okay, I'm seeing a pause stop recording button, so I think that means the recording has started.
I think so. I got like a notification when you started. I was like, "You're being recorded," like the fun consent one.
Great, that's a good sign. We'll give it a few minutes to give people a chance to log in, maybe start at like 10:05. Okay, well, why don't we go ahead and get started? Thank you all for joining us today. We are going to be hearing from Courtney Wiesepape and Laura Faith talking about integrative metacognitive psychotherapy for personality disorders, addressing self and interpersonal difficulties. So the first part will be their presentation, and then they'll leave time at the end for questions and discussion.
Okay, welcome everyone. Thanks for being here. Can everyone see the PowerPoint slides okay as of now?
Yes.
Okay, perfect. So, as Jackie kind of introduced already, we're going to be talking about metacognitive therapy, specifically merit, for personality disorders, and how merit can kind of work to address self and interpersonal difficulties. So a lot of this content came directly from a paper Laura and I wrote fairly recently. It's still under review, so we haven't quite gotten feedback on it. But stay tuned for that, hopefully in the next few months. Let's see. Okay. So the first thing I'm going to chat about with you guys is personality disorders, how we kind of think about them, and some changing conceptualizations of personality disorders and what that kind of looks like in treatment. So we're probably all pretty familiar with the current DSM classification system and diagnostic criteria for personality disorders. Broadly, it's going to include a pervasive pattern of self and interpersonal difficulties and kind of result in significant functional difficulties, whether that's in relationships, employment, kind of a variety of areas of functioning. There are some like limitations with that, though, as we probably have thought about in the past. And part of that is that there has been traditionally like limited treatment options for personality disorders. Of the treatments that are well researched and well supported, right, they tend to focus on basically DBT for borderline personality disorder. That's been kind of the vast majority of the research on treatment for personality disorders. And although there's been some efforts to create or look into other treatment options, I think we're all like very familiar with the idea that DBT is kind of like the gold standard treatment specifically for borderline personality disorder. Another limitation, or maybe a bit of a critique, is that our current diagnostic classification system is categorical, right? So you get a label, you get this diagnosis of borderline personality disorder or schizotypal personality disorder, and that's kind of it. It's an all or nothing type approach. Categorical diagnostic systems have been heavily critiqued, especially recently, for kind of oversimplifying pretty complex disorders, having like a high rate of overlap between diagnoses, and then this kind of sense of like arbitrary cutoffs between what's normal and what's abnormal. So kind of taking this all together, there's a growing popularity of focusing on more dimensional approaches. And the one we're going to talk about today is the alternative model of personality disorders, or the AMPD. So a bit more about this model. It is a hybrid approach, right? So it's including some categorical and dimensional components. And we're going to focus, I guess, primarily on these first two criterion, so A and B. So criterion A is going to include those disturbances in personality functioning. That's further kind of broken down into disturbances in self-functioning and disturbances in interpersonal functioning. So For self-functioning, this model kind of states that there are challenges or difficulties with identity and self-direction. On the kind of interpersonal side, there's challenges with empathy and intimacy, which are both kind of required to develop some of those stronger interpersonal relationships. And then the second half of this, right, are kind of these 5 trait domains. So negative affectivity, detachment, antagonism, disinhibition, and psychoticism. Those are going to encompass 25 trait facets overall. And this allows for the diagnosis of 6 kind of distinct personality disorders. So this is where that kind of categorical approach is still hanging on and lingering a bit in this kind of model. With all that said, we're going to focus more on kind of the first half of the model and how that plays into a metacognitive approach. Okay, so this is probably quite familiar to everyone, but I will give a review to do my due diligence. So thinking about the integrated model of metacognition, how do we define metacognition, right? In this model, it's going to include a spectrum of activities ranging from the ability to identify discrete thoughts or emotions. So being able to say, like, I'm feeling angry, I'm having the thought of X, Y, or Z. And then it's going to range all the way up to this ability to integrate pretty complex narratives into this broader, evolving personal life narrative. So kind of the big picture stuff. Metacognition includes self-reflectivity, understanding the mind of the other, decentration, and mastery. So when we think about self-reflectivity, we're thinking about the capacity to reflect on the self exactly as it sounds, right? So being able to identify thoughts and emotions that one is having, being able to recognize that one's thoughts might be inaccurate or wrong, and being able to integrate kind of multiple narratives across a life story. Understanding the mind of the other is similar to self-reflectivity, but focused on a specific other person. So the ability to say, oh, I think Laura is having this thought right now, or I think Laura is experiencing this emotion, and kind of being able to look at this other specific person, make guesses about them and what they're up to, and be able to see them as a holistic person with a life story and multiple narratives kind of integrated. Decentration is going to include the ability to basically understand that you are not the center of the world and that everyone is an individual person with a complex life story, right? And you're not necessarily like tied into that. So we're thinking about kind of the conceptual opposite of the experience of centrality. And then finally, mastery is the basically ability to identify and manage psychosocial challenges. That can range anywhere from not having a good sense of what psychological problems you might have, all the way up to using like specific metacognitive knowledge about yourself and others and the world to pretty holistically respond to those psychological problems. So we are essentially proposing here that the integrated model of metacognition is a great framework to start to address and think about those self and interpersonal disturbances in personality disorders, and can definitely help with the more personalized treatment aspect. So a couple slides ago, we kind of talked about how right now sometimes it feels like it's just DBT as like the gold standard treatment, and you don't have many other options. So we're kind of putting forth the idea that this model of metacognition and merit by proxy can be like a really good direction to head to think about how we can maybe start to use more individualized treatment for people who have personality disorders. So kind of broadly, people who have a personality disorder may struggle to form a complex identity. They might have trouble understanding other people. and might be unable to respond to psychological and interpersonal challenges due to metacognitive deficit. So this is for the visual learners. Um, on one side of your screen, you see the kind of components of the alternative model of personality disorder. So you see the disturbed self-functioning and what goes into that, and then likewise for the interpersonal functioning. On the other side of your screen, you see the core domains of metacognition. And what we're going to do now is think about how they kind of line up with each other. So I spent a lot of time making these animations, unfortunately. But when we think about identity, right, like self-identity, that aligns really well with self-reflectivity. For self-direction, also going to align pretty well with self-reflectivity and mastery, right? So as you're kind of thinking about how do I want to manage my psychological problems, psychosocial stressors, and continue to move forward in my life. So self-direction is really going to play into mastery as well. When we think about the interpersonal functioning aspect, right, thinking about empathy, that's going to play in kind of in this like in-between area for understanding the mind of the other and decentration. So being able to understand other people in kind of holistic and integrated ways, and to kind of like view the world as a collection of individuals are both going to be relevant for empathy. And then intimacy is also going to kind of align with understanding other people, right? How can you develop strong relationships and have empathy for other folks if you don't have a good understanding of other people? Um, just kind of quickly, some evidence for the idea that metacognitive deficits exist in personality disorders, right? Because metacognition tends to be our treatment target. If people with personality disorders didn't have any deficits in metacognition, our whole approach would maybe not make a lot of sense for them, but they do. So metacognition has been found to be impaired in a range of personality disorders, with the severity of personality pathology being related to level of metacognitive dysfunction. One study found that deficits in mastery persisted even after 16 sessions of psychotherapy, specifically to borderline personality disorder. Those individuals tend to have lower levels of decentration and mastery. And essentially, multiple people have kind of theorized or discussed the idea that metacognition is this core underlying element of personality pathology. Merit, again, something we're all pretty familiar with. But Merit obviously uses the integrated model of metacognition to kind of like make sense of people, right? And think about the struggles they may have, and how they're managing and moving forward in their lives. But Merit overall is a psychotherapy model that focuses on building metacognitive ability through 8 elements, which we'll talk about a bit more on the next slide. Laura is going to talk a lot more about this in the second half of the presentation, but we are proposing that Merit offers a unique approach for the treatment of personality disorders, and we'll talk a lot more about how that is in the second half. And then, of course, Merit can target these core personality pathologies proposed by the AMPD, like those self and interpersonal disturbances. So we kind of think and argue that, like, by targeting some of our core metacognitive domains, that's going to similarly target those self and interpersonally disturbances. And then finally, Merit allows for individualized treatment based on the presenting problem, specific personality trait pathology, and core disturbances. So using a more dimensional model, you have theoretically like a bit of a better understanding of what each individual is struggling with, and you can use merit to start to, I guess, better target some of those things in a personalized way. Okay, so merit elements. There are 8 of them. I will not spend a ton of time on each of them, but I think it's important to review because we are going to be talking about each of these elements in the second half of the presentation when we're kind of talking about interventions more specifically. So we're probably pretty familiar with these things, but element 1 is going to be focused on the client's agenda. So thinking more carefully about what an individual is bringing to a session, right? Their hopes, their desires, what they want to get from the session that day. Agendas can change over multiple sessions, over one session. They can sometimes seem in conflict with each other. But element 1, right? Focusing on that agenda and what someone's bringing to the session. Element 2 is insertion of the therapist's mind, so that the like willingness and ability to share your own thoughts with someone, your own perceptions of maybe the person, of a specific situation. And I think the overarching goal of element 2 is to really become a partner in dialogue with someone, be able to build that intersubjective space and have a conversation. Element 3 is eliciting narrative episodes. So getting those really nice, specific examples, hearing about different narratives across time with the goal of starting to link those narratives across kind of time and space, and maybe identify themes across a life narrative overall. So that's element 3. Element 4 is defining the psychological problem. So essentially, for this, we want to have like a mutually agreed upon challenge or struggle that we're thinking about together. This is often not a specific symptom or like diagnosis that someone has received, but rather something that both people can understand and think about together. So maybe instead of saying, my main psychological problem is hearing voices, maybe something that we can better reflect on and agree upon with one another is like a sense of loneliness or otherness that might come along with hearing voices. These next 2 elements are process elements. So thinking about what's going on in therapy. The first one is focused on the therapeutic relationship. So just like maintaining an ability to acknowledge like ruptures and repairs that might happen over time in therapy. Thinking about that intersubjective space between 2 people and what that means or what that might look like, challenges that might come with that. Element 6 is focus on progress. So checking in with the individual, maybe at the end of session, saying like, hey, how did things go today? What has changed as a result of therapy? What's different after this session? And just maintaining that focus on progress or change over time. The final 2 elements are subordinate elements, and those are focused on our specific metacognitive interventions. So element 7 is stimulating reflection of self and others, right? So when we think of self-reflectivity and understanding the mind of the other, element 7 is focusing on trying to move someone kind of up that scale, right? So if someone is functioning at an S3 level, they can identify their thought, but they can't identify emotions that well. Kind of our interventions would focus on scaffolding that ability and pulling someone from S3 to S4, right? So being able to identify emotions in oneself. Element 8 is our last element, and that's going to focus on stimulating mastery. Um, so being able to identify psychological problems and kind of deciding how you want to begin to address those or manage those or cope with those or move forward with your life kind of despite different challenges or problems you might have. And that's merit. Those are the 8 elements. At this point, I think I transition over to Laura.
Courtney. So first, I'm going to start with talking about self-functioning in this alternative model and how we focus on some different areas to target self-functioning with these merit elements that Courtney went over. So again, in this alternative model of self-functioning, they propose that identity and self-direction are the areas underneath self-functioning that are important. And again, the idea that people with personality disorders have this difficulty developing a stable and integrated idea of self and agency or self-direction. And so an overall goal, of course, of merit is to help people be able to integrate this idea of themselves. Potentially somebody might come to you who's very fragmented and has a chaotic life, and so you help them develop this more stable idea of themselves. And so this second bullet, I will talk more about these areas, but just so you have an idea of kind of where I'm going, merit can target these specific aspects of self-functioning, including agency and self-direction, getting these narratives from people, narrative identity, and then integration of this stable sense of self. Okay, so thinking about agency and self-direction. So what someone wants to do in their life, what sort of direction that they would like to go in their life. So first, thinking about element 1, agenda. So again, Courtney went over this, but what the patient actually wants. What are they coming to session to talk about or discuss? What are they wanting from the therapist? And so this helps promote agency or self-direction by putting their agenda at the forefront, never putting your agenda as the therapist more important than the patient. And so that kind of bolsters their agency of what they actually want to do. For example, if a patient comes and is wanting to talk about the therapist, they're not wanting to talk about themselves. And so the agenda might be that they don't know what to talk about. The agenda might be that they're uncomfortable. They want the therapist to talk more about themselves. There might be avoidance going on. And so whenever for element 1, the agenda, the therapist is bringing up these potential wishes or desires to elicit a discussion about that and what the patient might actually want from the therapist. Element 4, the psychological problem. This is another way to promote agency or self-direction. So in this element, again, you're forming this joint idea of the patient's psychological problem. And so the goal is really to improve this sense of self and understanding of difficulties so that the patient can direct their own life. And so, again, it's usually not like some kind of symptom. It's a relatable psychological problem that helps the patient identify what has gone wrong in their life, what is the thing holding them back, or the series of things holding them back in their life, and so that they can understand the psychological problem and they can know better sort of how to address this psychological problem. An example listed here is that the patient might feel abandoned when a partner steps away from a disagreement. So that might be some kind of psychological problem that the therapist and patient might develop this joint understanding of the patient of the psychological problem. You might also use narratives to understand the psychological problem. And eventually with the patient might be able to develop this sort of integrated idea of the psychological problem. You might identify patterns over time. And that would be kind of a more advanced level of metacognition for the patient to develop this idea of a psychological problem. You may start with something more discrete, like some some kind of psychological problem that relates to how the patient feels, this feeling of being abandoned. And then you may develop a more integrated idea from there as therapy develops. And always in Merit, the therapist is seen as a co-participant or consultant within this intersubjective approach rather than the therapist being the expert. And that always helps promote agency because the patient gets a voice, basically. They are the person who is in charge of their life, and the therapist is serving more as a consultant rather than the therapist being the one to offer their expert opinion or being the person that's kind of figuring out my ideas of what the patient might do with their life. Rather, I'm asking the patient, where do you think your life is going? What kind of problems do you have? What would you like from me today in therapy? Rather than me setting the agenda or me sort of identifying what I think the psychological problem. It's always collaborative and always this intersubjective space between the therapist and the patient. Thinking about narrative identity and develop this sense of self through narratives. And so element 3 is eliciting these narrative episodes. So that is a huge important part in Merit that we think of as something very important to help someone develop this sense of identity. And so you may start with these discrete small narratives in someone's life, maybe day-to-day life, and you may eventually get to the point where somebody is identifying these more complex narratives throughout their life, and eventually they may be able to connect two narratives. They might be able to start to connect multiple narratives across their life. That's kind of where you would hope things get. And then for someone to be able to develop these integrated narratives, a narrative identity, you may need like a higher level of metacognition to evolve with novel experiences. And so in order to evolve your narratives, then you need a higher level of metacognition. And so you're using all of the Merit elements to be able to scaffold metacognition and build from discrete identification of thoughts, for example, into these more complex ideas of yourself and others. And without the ability for narratives to evolve, your identity might be stagnant or without larger purposes. And so to be able to respond to different narratives, your narrative identity can evolve from there. So again, a huge goal of Merit is for this integration to occur. And so people may come to therapy with a very fragmented idea of themselves. They might have a really sort of unstable idea of who they are that might be changing with the chaos in their life. And so you're using these superordinate elements to be able to build metacognition. And so listed here, elements 7 and 8, stimulating self-reflectivity and stimulating mastery. And so interventions to target a patient's understanding of self will range, and it will really depend on when they come to therapy, what level of metacognition they are in terms of self-reflectivity. So if somebody comes to therapy, for example, and has the ability to identify discrete thoughts, you start there with them. And so you may scaffold their identification of emotions. So as a therapist, I might share my different emotions that I experience, or I might ask them specific questions of different thoughts that they might be experiencing, and I might share that interpretation in session with them. So you may start there with somebody and build from there. Once somebody gets to the point where they're able to identify patterns, they may share some narratives about themselves, and you may talk with them about their thoughts and emotions within those narratives. You might start to connect the thoughts and emotions, and eventually you might form more integrated ideas of what's going on in their life and be able to again, start by connecting the thoughts and emotions, these discrete cognitive operations, and then be able to actually connect the narratives of what's going on in the person's life. And those would be higher levels of metacognition. And once you do that, that promotes agency in the person's life so that they can understand the narratives in their life and understand kind of what has happened across time so that they can start to form their own ideas of these patterns across time. And so they can think about what they want to do with their life, how they might address psychological problems, these patterns across time, and then it helps them direct their own life. And with stimulating mastery, similar idea to talk to people about their psychological problems. And so someone might, again, come to therapy not knowing really what the psychological problem is. So that is often the first thing you do with somebody is to kind of figure out what the psychological problem even is. And then discuss with them what kind of mastery strategies they're already using to respond to these problems. They might not be doing anything yet that's really active in their life. They might be avoiding the world completely. They might be avoiding different people or different things in their life. And you may help them develop more active strategies to respond to problems in their life. They might start to seek support from you as the therapist as something a little more active, coming to therapy and seeking support and seeking advice in therapy. And then eventually the goal is to help them form these ideas of metacognitive strategies where they're really responding in a personalized way for themselves, of responding to problems. Of depending on the situation, they might do different things to help themselves in that situation in a personalized way. And so they eventually have this more integrated, complex idea of who they are. And so they can use these integrated, complex ways to respond to problems in their life. Okay, so moving on to the other area of criteria A of this alternative model, interpersonal functioning. And so this includes empathy and intimacy within this model. And so these are areas that Merit can address and think about. And so this model thinks of interpersonal functioning with people having difficulty forming lasting relationships, poor social cognition, isolation. So people can have difficulty with a range of different things related to interpersonal functioning. And you think about each person, kind of what they're dealing with in their life. And so Merit can target interpersonal functioning with understanding others, like people in their life, and also the therapeutic relationship, since Merit is a very intersubjective therapy. So thinking about understanding others in terms of Merit, so we have here element 2 and element 7. And so element 2 is one of the content elements that Courtney talked about. And so it would be moments where the therapist might share their mind of things that are going on. And so the therapist shares their thoughts to scaffold these metacognitive processes. Again, I mentioned earlier, if a person comes to therapy and they can identify discrete thoughts, but they can't identify discrete emotions. And so the therapist I might share my emotional reactions to things. I might scaffold ideas and ask the patient, if they're talking about a narrative, for example, I might say, what were you feeling in that moment? Were you feeling happy, sad? I might suggest certain emotions in the moment. And I might have my own reactions to the patient. And so if a patient avoids me and doesn't come to therapy, and I might share my thought or my reaction on that, I might say, oh, it felt like you were avoiding me. What was going on there? I was surprised that you didn't show up to session that time. I might kind of share my reactions in the moment to the patient and scaffold my thoughts so that the patient is forming this idea of my own mind. And so it gives them the opportunity to think about me as a person, my reactions, my thoughts. And eventually they might start to form a more integrated or complex idea of my own mind as the therapist as you get to know the person. And in Merit, it is a therapy that we consider longer term with at least some of my patients. So we might have the opportunity to actually work with somebody for 6 months or a year, or multiple years. And so the patient may have that amount of time to be able to really form these like complex ideas of the therapist. And another thing with element 2 is and share your things about you in your life as a therapist. And so this may also help the person build their decentration to be able to understand that the therapist has their own life, even outside of the therapy room, and help build that area of metacognition as well. Element 7, understanding the mind of the other. And so this is one of the superordinate elements where you're stimulating, depending on which level the person is at metacognitively, you will start with where they are and scaffold from there. And so again, similar to self-reflectivity, the idea is to build metacognition in order to help someone form these more complex and integrated ideas of other people. And so I think in therapy with somebody, this often happens in the context of maybe narratives. And so the person might share these narratives about chaotic relationships they have in their life. They might be relapsing on alcohol and they have these ruptures with people in their life where they get into arguments and they're drinking and they have these issues with other people. And so depending where they are metacognitively, we might talk about how those other people might be thinking or feeling or reacting to the patient's behavior. And I might invite the patient to talk about what they think that might be happening with these other people in their lives. I might listen to the patient of their narrative of what has happened, and I might share my own ideas. Like, I wonder if maybe the person was thinking this, or I wonder if this was going on, or I think they might have been feeling this. So it might kind of look like that, just to kind of stimulate them thinking about other people. So within the therapy room, I might use my own thoughts and reactions, but it can be also really helpful to think about other people in their lives so that what we're doing in therapy can translate to their life and what is actually happening in their life. So eventually the goal really is to help the patient identify these patterns in their relationships and start to form these interpersonal schemas so they can understand what has happened in their life across time. And depending what the psychological problem is, they might be able to kind of form ideas of like, what are these interpersonal schemas? What's happening across time? And be able to develop these more healthy mastery strategies to be able to have healthier relationships if that's what they would like in their life. So again, thinking about the therapeutic relationship, so with the therapist sharing their own mind, that's kind of in discrete moments of me sharing kind of what I think. With element 6, the therapeutic relationship, it's a process element. So we're talking about kind of the relationship overall, like what is the process happening in therapy with patients at the start of therapy. I often ask them like how they think therapy is going, like what is it like getting to know me? And then as therapy goes on, I have a few patients now that I've worked with for a couple of years now or even longer. And I might share my thoughts on how our therapy relationship has changed over time. I might ask them how it's changed with me. There are some patients, for example, who might like avoid coming to therapy and the engagement is really poor in the beginning. And then something changes at some point where they're coming every week and we're talking every week. And so asking them what has been their experience of the therapeutic relationship, is what has changed over time to help you come to therapy, feel more comfortable, and actually engage in therapy. And so as you talk about this therapeutic relationship as is happening in real time, it may lead to discussion of the patient's relationship outside of therapy. So if the patient had difficulty trusting me, they would only come to therapy once a month, then no show 3 times a month. Is that sort of process happening in your life where you have really a lot of difficulty trusting other people, avoiding them completely, not really feeling very comfortable with them? So what's happening in the therapy room might translate pretty well to what's happening in their life. And so in these discussions, it would offer these opportunities for collaboration with me as the therapist, and model using these metacognitive skills. And so if I'm really open to talking about the therapeutic relationship and what is happening, and I'm kind of talking about like what I think is happening in the therapy room, that offers the opportunity for the patient to talk about these potentially difficult things to talk about. And ruptures, for example, are really important to talk about and can be really helpful in the therapeutic relationship. So if a rupture occurs, the patient stops coming to sessions completely. When the patient returns, it can be a really helpful discussion of sort of what happened, what was going through the patient's mind, why they stopped coming to therapy, what was going through my mind, kind of what my experience of the rupture was. And so that can be really helpful in the therapeutic relationship. Also, in a rupture, as it's happening in the moment, that could be a really helpful discussion too. If you're having a difficult relationship, asking the patient in the moment, like what's going through their mind. It seems like something just happened there. Can we talk about it? And sometimes that is something you can do, but sometimes it is where the patient might just stop coming and then you realize a rupture happened later and then you have the opportunity to talk about it maybe after it happened. So that also happens too, obviously. Okay, so thinking about the existing evidence for merit in treating personality disorders. And so a lot of the merit research right now is randomized trials that have been done with a variety of populations. A lot of them are psychosis, but there's also studies with personality disorders. And so, randomized trials, many of them are with people with schizophrenia diagnosis or it's like psychosis spectrum disorders. And there's also studies with personality disorders. So there's lots of case studies. So there are case studies with schizotypal personality disorder, borderline personality disorder, and others. And there's also research with other types of metacognitive therapies that have similar approaches that are effective in reducing personality pathology. But really, more research is needed. And so we have some research emerging that really shows that this approach is effective. And there's more to be done also at this point. So just to conclude and kind of think about what we talked about today, in terms of conceptualization, this integrated model of metacognition is one way to conceptualize what we think of these core disturbances in personality disorders, namely the self and interpersonal disturbances, and it fits really nicely into this emerging alternative model of personality disorders. And so it fits really nicely into that of this hybrid model. And Merit utilizes this integrated model of metacognition to address these deficits. And the idea is that people with personality disorders have these metacognitive deficits that contribute to the self and interpersonal difficulties. And so we can help people improve those specific areas using the different elements, the 8 elements of merit that we discussed. And so we need more research with this empirical data to explore the ideas that we talked about. And there is some research out there, but continuing in this area will just build upon this evidence that already exists. So that concludes the ideas that we have. I don't know if you have anything to add, Courtney, but if not, we have lots of time for questions and discussion.
I just want to chime in. Can you hear me, Laura?
Yes.
Oh, I just want to chime in and say that I really appreciated some of the clinical perspectives in terms of rupture and repair, as well as giving feedback to the client about some of those process comments and your experience of them, as well as that's something I'm currently developing in my therapeutic work. So just wanted to say thank you for that.
Thanks, Denise.
I found myself thinking a little bit about some of my experiences I've had offering merit to people with personality disorders. And one thing in our setting, and I suspect this may be the case uh, for the two of you in VA settings as well, but a lot of times when somebody has reached me, they've already been exposed to like a bunch of DBT skills um, or other kinds of like related approaches for especially for borderline personality disorder, and have had like a lot of sort of adversarial treatment experiences maybe at the hospital. And I do think that the kind of general spirit of merit and then some of the particulars as you laid out do really help try to work against some of those just kind of like negative or iatrogenic experiences of treatment, to really reinforce someone's agency and their kind of role in their treatment rather than just being a sort of recipient of skills. Um, it's almost more than anything else, just sort of like undoing some of the negative effects that were unintended. So I don't know if you have thoughts about that or have had similar experiences in your own work, but I found myself thinking that as you were talking.
Yeah, I've had similar experiences, and it sometimes it feels like I am like trying to repair ruptures that did not even happen with me, which can be tricky. I'm thinking of one guy who I'm working with right now who's like quite quite angry, and for the first like 6, 8 sessions for weeks we were meeting, and he just brought like so much hostility and anger into the room, and it took me the 6 to 8 weeks even to like form any start of a therapeutic relationship with him. Um, so I think merit is so nice and that it like allows that to happen and allows like the time and space to have some of those repairs start to occur. Um, I don't know, just thinking about like the interpersonal aspect, I feel like merit does like a really great job of allowing some of those interpersonal dynamics to shift and change with time just by, I don't know, just like how merit is, right? Like I'm just trying to like get to know someone and like talk with them. And I feel like so many people with personality disorders have, like you said, like not had very positive experiences with therapy, and merit can be really, I guess, like reparative in that way.
Speaking of a guy that I work with who wasn't so much related to previous treatment that he went through. I've actually had less patients that did like DBT stuff before coming to me, but I think just in his life, his low agency was kind of reinforced because he put himself into this um, strong patient role where he was somebody that couldn't really do much in his life. And I think other people kind of reinforced that. So I feel like in therapy with him, we really focused on agency for probably the first 2 years, just building up his sense of self-direction, where he can direct his own life, and it's not up to me, and it's not up to these other people in your life to tell you what to do. And I think now he is at that point where he realizes that he does have a voice, and he can really like do things in his life, and he can make decisions. He's an adult. And I think I kind of use these merit elements a lot, but really had this agency, low agency in my mind, and like building his agency where he is at that point. And I think that was a necessary element of him moving forward in his life, knowing that he is the person who has the control and he can make these decisions. And he's starting to do that now that he actually can think about his role in his life, which he didn't really before. He just thought he was a sick person. He can't really do much in his life. So it just makes me think of him too.
I'm wondering if you all have thoughts on how this might look different with different like types or personality disorder diagnoses, or if it's better to like conceptualize people with personality disorders just kind of as generally having like long-standing interpersonal difficulties.
A good question. My initial reaction is I wish we knew a bit more about like the differing metacognitive profiles in different personality disorders. There's been some of that work that we talked about with borderline personality disorder and those individuals having lower, I think it was decentration and mastery. So I don't know, my initial response is like, man, if we just like knew a little bit more about those metacognitive profiles and how they differ like diagnosis to diagnosis, maybe we would have like a better sense of like, here's what merit might look like for someone with borderline personality disorder. Here's what merit might look like more specifically for schizotypal personality disorder. But I guess with that being said, right, like as we work with people, we have a pretty good sense of what their metacognitive functioning is like. And I think that even like that individualized piece can really help target different things, right? So if you're finding someone has lower self-reflectivity, maybe focusing more on those like identity pieces and the self-direction pieces could be most beneficial. Laura, I don't know if you have additional thoughts about that.
Yeah, I completely agree with that. I think it would be really helpful to know the different profiles, to know kind of what to look out for. I think just thinking about my own experience with people with different personality disorders, at this point, I've had a lot of people who are really avoidant. I've also had a lot of people who are more sort of on the like deceitfulness scale, I guess. Um, and maybe this is an obvious point, but I think like the themes of like what is happening in the content can be really different. And so I think me as a therapist, I feel like my role was maybe a little bit different, or I look out for different things. For example, with the really avoidant people, I feel like I need to be really patient, and if they don't show up, know that something's going on. It might be related to avoidance. So I guess it's another like thing to sort of look out for, versus the people who are have this difficulty telling the truth, I guess, of making sure that I'm bringing my thoughts up of what I might think is happening, and kind of help them think through like what might be happening with our discussions and their life related to um, not telling the truth. So that's one thing that comes to mind, is just thinking about these different facets in the alternative model of things happening, which we didn't talk about that as much today, but maybe that's another sort of future direction of something that we can think about. And I think those conceptualizations are helpful for me to kind of think about like what to look out for, in addition to maybe the potential profiles that we don't really have research on yet.
Yeah, I appreciate those thoughts. As you were talking, it was coming to my mind that like I've worked with a handful of people with more like narcissistic traits, and I've found like discussing the therapy relationship is really difficult in those situations. So yeah, I'd be curious as the work progresses what that looks like.
Thanks for this. I was similarly curious if you felt yourself pulled in like a different direction as a therapist. I found, especially if people have gone through like DBT, they maybe like the rigid or like very skills practical approach, and that is like very incompatible with what I think they need and what we're trying to do. So I was just curious for folks with BPD or even other conditions, like, do you find yourself pulled in different directions when applying it in this direction?
Not as many people that come from DBT, so I can't speak to that. But I think I definitely feel pulled in different directions with agendas, of course, which probably has some kind of relationship with the different people on these different dimensions. Like somebody really avoidant might want me to sort of chase them and call them a million times to invite them to come to therapy. Um, And so I think that that definitely plays a role, and I'd like to know more about that of how these different like profiles relate to, I guess these different agendas, like wondering what that has. But related to what Courtney was saying earlier, I mean, I think like some of it feels like undoing some of these things in therapy that have happened. So maybe that's kind of a point of discussion with somebody, um, how the previous types of therapy have been helpful to them and why they're bringing these things up now and kind of how they see therapy now, and our idea of therapy or our agenda might conflict with theirs, of course, and so that would be kind of another discussion to have with them is what I imagine, because merit looks really different than DBT. So if somebody's coming from that space, then yeah, I think there kind of has to be some kind of discussion, because if somebody's expecting like a DBT type therapy, and of course merit is an integrative therapy, but it would look different for them in some way.
Jump in for a second question. Have also been reading Nancy McWilliams and her psychodynamic approach to using personality for diagnosis and treatment, and was curious if you know of that and how merit like might be similar or different to that approach.
That's a good question. I'm not super familiar with her work, so I cannot speak to it, but it sounds interesting. I already Googled her and am planning to look into it a bit more.
Just gonna say a joke and invite Sarah to speak to her, because I know Sarah has encouraged me to look into her work. I think it's definitely relevant, but I don't have thoughts on it either because I'm not super familiar. I see Sarah put her camera on because she's eager to talk about this.
No, I just felt called on by you. I love McWilliams, and I am always badgering Laura to read her. But I also just popped back into the presentation, so I don't want to make assumptions about what was said. But I do think they are, with merit being integrative, I find it's relatively like natural to integrate some of McWilliams's ideas and conceptualizations into your merit approach. So I don't see them as being divergent in any like significant way.
I can speak to that a little bit. I also agree. We talked a little bit about having a profile, right? And that there's more research to be done. And I think McWilliams' work kind of outlets some of that. You can think about what are the defenses core at the center of personality pathology and use that to guide your interventions for merit. So like, I know McWilliams speaks to in a histrionic personality disorder, the therapist would follow the affect. And so I can highly correlate that with the merit elements and deficits in metacognition as far as identifying emotions. And I also think, too, across all personality disorders, the elements that merit offers focused on interpersonal aspects are definitely key. I find for me the most difficult is when I'm presented with a client who has dependency traits, dependent personality disorder, and especially related to mastery, where their identity is so enmeshed into not being a master of psychological distress and the fear that if I can take care of myself, maybe I won't have people in my life. And so I do think that also relates to individuals who have had other treatments like DBT skills, where they come to me and they hope that I could teach them something, that I will guide them, and they're very distraught and confused when I suggest that they're in charge of their own recovery, and this is a self-directed therapy. So I was curious if anyone else has run into those challenges and how they might address them. Thank you.
I had a similar thought, Jackie, that was like rattling around in my head. I was trying to figure out how to integrate all these different ideas. So maybe I'm just restating like the same question in a different way. But I think for one of the things that I've noticed in working with people with a lot of personality pathology is that they often like kind of resist meaning making. So I don't know if that's like different than kind of what you're suggesting of like they don't want to be an agent necessarily, but I think sometimes folks come in with these like very rigid ideas about who they are and like the narrative that they want to share with you. And I think that can be exacerbated by having like exposure to DBT or other therapies that really kind of crystallize this like patient role. But I found that like trying to get people to explore like other narratives or to think about a narrative with me is really hard because they want it to be the kind of agreed upon narrative that they already have in their mind of like either I am like I've had all this trauma, I've been wronged by these people, or I am a persecuted person, but it's really hard to think in more flexible ways. And so I was thinking about that a lot in the presentation from Courtney and Laura's thoughts of like just the role of narrative, but it's also like, I think it's like Merritt's asking them to do something different where it is like to think with someone and to like make meaning of these things. And sometimes that to me is like the hardest kind of obstacle to overcome initially. And it seems like once you can get that going a bit, then the therapy seems to take off and it feels a lot more like like we're going in a good direction to me. But I think that is often the hardest piece with folks with personality pathology in particular. I don't have the same kinds of obstacles, I think, with more psychotic patients, but I think definitely this like joint meaning making piece seems to be really challenging for folks with PD.
Yeah, I was thinking.
Oh, sorry, Laura.
Go ahead, Jackie.
I was just thinking, we have a client right now who her script is to come in and tell us all the stresses and why she can't change. And it took a lot of patience and months to even have one new narrative presented in the therapy. And I think a lot of times the agenda is I don't know myself. I don't know my own identity. And so it's hard to tell someone else a different story or different part of their life. But I think that's a good reminder and a good appreciation of how hard it might be for the client to come up with a new narrative or to think about themselves in a new way. I appreciate those thoughts, Bethany. Thank you.
I was thinking about some of the patients I have that have these dependent traits, and some of them just feel so entrenched or pervasive. Not to say that they can't change, but it does sometimes feel like it can take a lot longer. And I guess the elements I think of that feel really helpful is like sharing my mind a lot, talking about the agenda, make sure I'm making sure I'm doing a lot of that, and encouraging different narratives, because it does feel a lot like the same narratives, a lot of times. And if those do happen, me sharing my mind of like these are narratives like we talk about a lot. Like, what do you think about that? But yeah, I'm thinking about one patient I have who tells the same narratives, and I think her narratives have diversified a little bit, but the pacing of things does feel different, and I just have to remind myself to keep sharing my mind and my observations of what is happening, and um, realize that the things that are actually changing and making sure we're talking about progress. But yeah, that dependency part is something that does feel really challenging within the context of this. And I think using the same elements, but maybe like emphasizing, like, I don't know, sharing my mind feels really important, or talking about the agenda a lot. So those are just my scattered thoughts.
This conversation kind of reminds me of some of the narrative work being done, and I'm most familiar with it in psychosis, but there's this idea that Paul wrote about shortly before his death, that like people with metacognitive deficits in whatever way, their narratives aren't very like responsive to new experiences. Like they just don't change very easily. And it seems like that's like part of what we're saying here, is that the narratives or narrative identity kind of broadly just doesn't change. And I don't know if I certainly don't have a solution, right? But thinking about like what elements outside of just like trying to elicit a range of narrative episodes, but like what elements really go into helping people like change or shift or evolve their narrative in some meaningful way, and what that looks like. Um, like a 60% thought, but that's what I have.
I think the first thought in my mind when you're talking is helping them become the agent of their narrative. I think that ties in greatly when we're working with clients that have, such low mastery. I don't know. That's my initial reaction to your point, Courtney.
Yeah. And the person I mentioned earlier that just like has so much anger and certainly has some like personality stuff floating around, we like pushed and pulled against each other for like weeks and weeks and weeks, and now we're just like talking about movies that he liked and it feels like something is finally happening. So that was a good reminder for me to like take a step back sometimes, and by talking about something that's not like his hatred, for lack of a better word, for society and his providers and the people he works with, I think he has taken on a bit of a more agentic approach in some ways. Not to say that talking about movies is the solution, but been beneficial in some way.
I don't know if this has already been said. I guess I'm sorry I missed part of this, but your discussion of narratives just makes me think of someone I worked with recently, where the splitting kind of behavior, or the way that like splitting showed up in her understanding of her problems, as well as like her how she like talked about other people, was so profound that it was really difficult from moment to moment to join her in anything. And it felt like her agenda was to demonstrate that she couldn't be understood, because, if you kind of agree with her on one thing, then she'll turn it on its head the next moment. It just felt like this like cat and mouse thing. And so it, as we were talking about that, it just made me think about the beginning of the presentation with the elements, where it felt like even agreeing on a psychological problem was pretty difficult, because if we couldn't agree on anything because the agenda was to demonstrate that I couldn't possibly understand everything that she's experienced, which is probably true, but we couldn't agree upon like somewhere to start. And so it just felt like this kind of like shifting ground game of whack-a-mole. And I'm just curious if people have thoughts about how to manage that type of presentation as well with a merit approach.
I guess my first thought is really focusing on the process of what is happening. Like you said, it always feels like you're on this like shaky ground, and as a therapist, sharing your frustration or whatever it is that is happening in the room, and focusing on that to get to kind of the next step or identifying psychological problem of what is happening. So maybe focusing more on like what's happening in the room moment to moment.
I think too, as you're talking, I'm thinking about agenda and what it would mean if someone would agree with her or does empathize with her or this person. I don't know if it's he or she. But what that could mean and what kind of fear could be associated with that. What are they afraid of? If you did empathize, would they lose you? Would you be abandoning them, or disappointed? So I think a lot of kind of the interpersonal process. And then another thought too, I think merit allows space for a lot of patience and understanding that, ruptures will occur. It's kind of part of the process. It's to be expected. And I like that it allows for a long-term approach. And so there's many ruptures and repairs over time. And I think the ruptures do allow for repairs and good conversations to be had.
I was thinking a little bit for the McWilliams comments kind of spurred some thoughts about like where merit sits relative to other contemporary approaches here. And it does seem like there's something about having this more integrative approach. But I think especially the emphasis on things like agenda and mastery that kind of positions merit as a good complement to both DBT and mentalization based therapy. And then I think by extension, contemporary psychodynamic approaches, but in a way that it sort of complements them differently. So I'm kind of interested in that, where it's like, I think that there's some space to draw on the strengths of a range of the contemporary approaches that seem to mostly be pretty equivalent in terms of outcomes, but are kind of like relative in popularity depending on what your setting is and what the local training programs are. And so it does, I don't know, I guess I'm reluctant to make just a completely biased claim that it's like, well, this is just, better than all of them. But it does feel like a little bit more, it allows for a little bit more of like a bigger tent to then draw on some of the strengths of some of the other existing approaches. Which I think maybe gets back to some of the comments at the beginning part of the talk about really allowing for more individualization, perhaps. But I don't know. I think there's some interesting like potential future directions of like both within personality disorder space, but also more broadly about like how merit is positioned relative to other like popular evidence-based practices and what are the, particular advantages that might, you know, I don't know, build up a little bit some of those existing approaches, or maybe safeguard against some of the potential unintended consequences, like risks of them.
Sounds like a good future Merit Institute talk.
Yeah, I think Merit also takes it a step further with like sharing the therapist's thoughts, or like the transparency of the approach. I've found the McWilliams chapters really helpful, particularly the parts that talk about like what to expect in the therapy room, or like the dynamics between the therapist and the client, based on like the different personality profiles. And so I find those helpful in like conceptualizing and understanding what's going on. But then after I read them, I also have to like find a way to then communicate that to the client, like share those ideas with them, which I don't think is like completely covered in the book. If I remember correctly, it's more just like a description of what's going on, and not like how to talk with the patient about that.
Yeah, I was just thinking I haven't unfortunately had a lot of work with folks with personality disorders this year on internship. But yeah, it seems like Merit would be able to sort of complement when if people have found certain skills or strategies that have helped them like think more deeply about what it is that those things are helping and like how it is that that's happening. Um, and I wonder if that could be particularly relevant for people with personality disorders.
This is a delayed thought, but makes me think of not my patient, but a patient that I have been involved with the supervision, that she did a lot of DBT and would just kind of parrot some of the terms that she used. And so on the surface, it seemed like she really knew DBT related stuff. But when you ask follow-up questions, it's just kind of empty. There's nothing really there. And so I think for some people, some of those skills are really helpful, but for others, they maybe just latched onto the terms, but it didn't really translate to their life. So I think having that discussion with them of what these previous therapies have meant to them, if they've been able to use them in their life, or if not, why. And so I think it can spark some really good discussions. And if some of these skills or things they learned really did help them, I think you can kind of obviously like integrate them into Merit or your treatment with them. So I think sometimes it can really help people and like build up their mastery in a way. And then maybe helping them get to like the next steps or higher levels of mastery to be able to sort of use the skills in more integrated ways where they're able to kind of use them situation by situation or respond to events in more complex ways or personalized ways for their life. So it just made me think of that.
I often think about Merit as like being able to help over like a pretty large range of functioning levels. right? So whenever I try to explain merit to like someone who's very CBT focused, I like talk about self-reflectivity and how people function at different levels and how merit can fill gaps and all those good things. And Laura, what you just shared made me think that if someone can't really do M2 or can't really identify like a psychological problem that makes sense and can be mutually reflected upon, like theoretically, they can't do M5, right? So they can't even use the DBT skills in like a way that is actually addressing or helping with whatever psychological problem they have. Yeah, Laura, that's what your thoughts kind of made me think of. There any final questions or thoughts or anything to share?
Thank you both for this great presentation and discussion. Kelsey wanted me to make sure to let everyone know about the September quarterly talk. We will skip August because I think most people are on vacation around that time. So in September, Sally Wasmuth will be here to talk about merit adaptations for occupational therapy. So yeah, thank you all again for your participation today.
Thanks, everyone.